Hi, AJ Heitman here, and we're on the EMS Today show. And it's a new feature that we're offering in this time of high electronics. And the whole purpose of the show is to find interesting people, interesting topics, not what you'd find almost anywhere else. And anybody who knows me, I can certainly find the people. And I have a good friend in Texas, Rihanna Ireland. She's an emergency physician. She and I have been communicating since March about the whole virus issue. And I think that she has a couple of things that we're going to talk about that EMS responders have to be aware of. We all think in EMS that we're caught into politics and in the confusion of the day. But when we were talking about a case a little while ago, and that's what we're going to talk about today, is a case where it maybe gets through the system and you and EMS might be transferring that patient, or you might see the patient a second time around. So Rihanna, welcome to the show. Give us a little background on your medical background.
Thank you so much, AJ. So my name is Dr. Rihanna Ireland. I'm an ER physician here in Texas. I've had some prior work as an EMS director, some work doing disaster. A number of years ago, I helped doing Ebola work. So disaster, virus, these are all things that are up my alley and things that I'm comfortable with. I've been following COVID-19 since we first started hearing about it in early January, and we've known it's been coming to our shores. And I think most of us really thought and expected we'd be better prepared, both in terms of testing and PPE and kind of streamlining politics so that people on the front lines wouldn't be caught up in kind of this political mess.
Well, we'll talk about how this is so much different because there's a lot of nervousness, emotional upset, people worried about passing it along to their families, and they have to understand that almost anybody could be a suspect these days. Is that right?
Yeah, I think part of it was initially we thought we had it figured out. The patients were going to come in with a travel history, B, shortness of breath, and C, fever. And so those were the patients we were looking for. We were not prepared to deal with patients coming in with loss of taste as their chief complaint, fatigue as their chief complaint, diarrhea or abdominal complaints. And so we were all prepared to wear our PPE for the patients that came in with respiratory and travel history. What we weren't prepared for is that some of our patients who came in with other complaints were going to end up testing positive. And because they came in with other complaints, we were going to see them without the appropriate PPE, and thus we were going to be exposed.
And talk about that sixth sense that we talked about. As a skilled provider, I used to be able to look at patients and just know that they had an aneurysm or know that they had congestive failure. And this is different because the symptoms are changing. In fact, just this morning, the CDC said that some patients may have no symptoms at all and still be positive.
Yeah, I've heard from some of my colleagues working on the front line that even their car accident patients who have no symptoms, who come in for something completely unrelated, they'll CAT scan them and their lungs will show changes in it consistent with COVID-19. So there's definitely a subset of patients who really don't have symptoms. And those ones, unfortunately, are the ones that are the most dangerous to us because we are anticipating that they're going to have symptoms. And when they don't, we just forget to wear our PPE or don't realize we need to. And so that's kind of created a bit of a battle between those who want to stay in PPE at all times and those that feel like PPE should only be utilized for the patients that we have a suspicion for. And that's something that's happening in all over. We hear from nurses, EMTs, even the police department saying, we want to wear our PPE all the time. And other places saying, no, you only need to wear it under these specific circumstances.
Yeah, my son's a highway patrolman, and he told me the other day that they're not getting their masks for 3 more weeks, which I think is just disastrous. You know, you pull something over on a traffic stop, and they could very easily be positive. Now, let me back up because I've always compared you to Mary Tyler Moore, where Mary Tyler Moore always had spunk. And if you remember, Lou Grant said to her, "You've got spunk." And then she was, "Oh, thank you, Mr. Grant." And he said, "I hate spunk." So you had an unexpected exposure. And that was early on in March. And I want to go through that case and have you go through that case because I think our audience has to hear that. about how that happened. We're not going to name any hospitals or patients or anything like that, but you know, we've been pigeonholed into this country, that country, this situation, this symptom, and your case really outlines that it's really not that way. So you have a patient that presents to you in the ER.
So I had a patient that presented to me in the ER, presented with something other than what I thought the symptoms were going to be. He had no fever, he had no cough, he had no shortness of breath, but his family brought him in because they thought that he needed to be seen and evaluated, and we did. And during the course of the evaluation, there were some things, there was some imaging that was done that made us suspicious. He also had a travel history. Both of those things made us suspicious, and so anytime you have a suspicion at that time, we were told to call our local board of health. So I did that.
Let's back up a second. When you saw a little bit on the CAT scan, you also did the lungs then, right? And what did
I
you
did.
see at the lungs?
So we saw ground glass opacities, which can be non-specific, but given that he also had a travel history outside of the United States near some areas I knew was affected, I felt like that was a strong enough case to just get him tested. You know, at that time, we believed that the Board of Health wanted to test everyone. We thought we could just call them up and say, these are my concerns. I'm a physician. I've made the decision that I want this patient tested, and the Board of Health would back us up. I don't think we, as clinicians, knew quite how political this was in terms of the local boards of health and the state boards of health not wanting to have positive cases. And the way you don't have positive cases is you don't test for them. So in my particular case, I called the local board of health. I felt initially very reassured. They had a physician's line. I thought I would be talking to other clinicians,
right,
and be able to explain. And what happened was I got shut down immediately. They said my patient needed to come from one of 5 hotspots. My patient didn't come from one of those 5 hotspots, and thus they refused to test him. And their decision—
Your patient came from a border country. That's a key point.
He did. He came from a border country, and given that he was sick, we couldn't tell exactly where in the country he had been in, how close to the other hotspot he had been. Was he right over the border? Was he completely on the other side of the country? So we thought just the fact that those 2 countries, one which is a hotspot and one of which was not a defined hotspot yet, the fact that those 2 shared a border would be enough in combination with the patient's symptoms to get him tested. And basically what we found was, instead of talking to people who could make decisions based on the evidence, that they just went and checked off a box. And because my patient did not check off that particular box, they just flatly refused to test him.
That's awful.
And yeah, and the thing that made it difficult is once the Board of Health issued their guidance, which was he's not a COVID-19 patient, it then became difficult to get him in the appropriate isolation. So now you've got a physician, me, arguing that the patient needs to be put in COVID-19 isolation, and our staff needs to be protected, and anybody who's transporting him need to be protected. And you had my Board of Health overruling me, telling our hospital administration, no, he doesn't. We've determined he doesn't need to be tested.
Okay.
Now, I did not take the local Board of Health's decision lightly. You know me. I actually ended up calling the CDC, getting a hold of a live person there who gave me, at the very least, an opportunity to overrule my local Board of Health by calling the state Board of Health. It was difficult to get a hold of them. It was a weekend. They weren't open. I actually managed to call an emergency line and get a hold of one of their operators and basically plead my case at 10 o'clock on Friday night that this guy needs to be tested. They gave me another avenue to get a hold of somebody who was the head of the Board of Health, who a couple of days later eventually agreed that yes, he warranted testing. So I thought, okay, I have done what I needed to do. We're going to get this patient tested. We'll find out. And I didn't know how difficult and complicated the testing process was going to be.
And how long of a time span is this now from the time you had a suspicion till you started your dogged determination to try and get him tested? Roughly
So
a couple hours?
I started, yeah. Once I had the results back of the imaging, despite having the no from the local board of health, it was just an unacceptable answer. It really was. And I knew without getting him tested, then I wouldn't be able to quarantine my staff. I wouldn't be able to get the room cleaned in the appropriate way, which is a terminal clean. There are lots of things that happen when you have a suspected or confirmed patient in terms of the personal protective equipment that physicians and other staff wear, how you clean the room, how you interact with the patient, how the labs are done. And so getting that diagnosis of him indeed having it was really important. And it took days. So after I saw the patient, I was so convinced that he had it. I never went home that night. I finished my shift and I drove to my husband's office with the clothes on my back. I missed my son's 9th birthday party with his friends and everything because I was so concerned that I was not willing to go home.
Now you had to leave that patient with the next team, so they had the same exposure, if you will.
They did. I had warned them, and I had actually shown them the things that I had found that was concerning. I was very clear with them. Yes, the Board of Health is saying he doesn't need to be isolated. My clinical judgment is he did. And so they actually were able to get their hospital to go ahead and test him, which was great. It took a couple of days back, and he in fact tested positive. And so I thought that was going to be the end of it. Okay, we had a patient, we had an exposure, he's positive. Now we're going to move forward in the process.
And now,
but I was wrong.
Now comes the World Health conundrum, right? And this is important for our viewers to hear.
So what I didn't understand was the politics involved in testing. So the local Board of Health is running a CDC-derived test. At that time, the hospitals couldn't get a hold of that test, and so they were running a test from the World Health Organization. So the CDC testers, the people who are using the CDC test, decided not to honor the WHO test results. So now we had a patient who was positive on one test, who wasn't positive on the CDC test, and the local board would not accept the hospital's test. And this is something that I wasn't prepared for. It seemed reasonable to me that other countries are using the WHO test. If they're positive on one, they should be assumed to be positive on all.
And you even saw in the lungs that you felt reasonably, and you shared that with them.
Yeah, I was very clear that this was definitely a COVID-19 patient. I had been in the ER. We know we're going to see some stuff firsthand. So I had been looking at CT scans. I had been looking for concerning things so that I could identify it if it came into my ER. And so I had identified it. This is it. Now I had a WHO test that was positive, and my local Board of Health said, well, he's not positive on our test. And so they released him back in the community and denied me testing.
Well, let's back up a second. Before that happened, though, you had to transfer him to another hospital, which meant that EMS was involved. And you told me you made sure that they were as aware and protected as possible because of your EMS background. You even showed them the X-ray so they understood their patient and helped protect them, right?
Yeah, my feeling was that I was sure enough that he was positive for it that I was not willing to let anybody else get exposed. I knew I was exposed. I knew my nursing staff was exposed. I knew my radiology techs that had taken him. We were all exposed. And the only thing that we could try to do at that point was to try to prevent other people from being exposed. Now, I know our EMS system or our EMS providers very well. And so I was very clear with him. This guy has it. Please protect yourself. Even in a time when we were running out of PPE, said, I will get you an N95 if you don't have it. I will get you goggles if you don't have it. But I actually had my medic who was in the back come down and look at the imaging with me so that I could say, I don't want you in the back with this. And they did. And thankfully, they ended up not having to be quarantined because they were wearing appropriate gear.
Okay, so now you have the other hospital who releases this gentleman back into the community, and then the second test comes back positive and they have to go get him.
Yep. So in the interim, so where we stand at that point was we had a positive WHO test, a negative CDC test. The Board of Health said the CDC test trumped the WHO's test, and they released the patient back into the community with a clean bill of health. Well, the problem was I developed a fever. 2 other people developed fever, and the only thing we all had in common was that patient. And so at that time, we were calling the Board of Health going, wait a minute, something's wrong. So they decided, given that we had symptoms and we were pretty forceful, to retest the patient. And when they retested the patient, he finally tested positive on their CDC test. But now he's got even more exposure because he's been in the community. And so
and your hospital room where he was at couldn't be in isolation. I mean, you're supposed to down that room, right? But you can't unless you know. Right.
And that's part of the problem, is that we have protocols for what to do with these patients, but that all is dependent on having an actual diagnosis. And I didn't have a diagnosis because I had the local Board of Health saying very clearly, this is not a COVID-19 patient. And so trying to tell my administrators, oh, but I think it is, when they are getting guidance from the Board of Health saying, no, it's not, resulted in us not doing the terminal clean, not taking that room out of rotation.
So let's go back now. So we got the patient finally handled. What about you and your coworker? Your symptoms were pretty clear. Did you get tested?
So I was able to get tested. It was a process. So what happened was, early on, when the local Board of Health and the CDC were not having that many cases, they would make you something called a persons under investigation, a PUI. Mm-hmm. So I got an official PUI number and documentation that was sent to the CDC that said that I could get tested. I thought, incorrectly, I thought that the local Board of Health would send somebody out to do my testing. And the answer to that is no. They don't do testing at the Board of Health. So they gave me a few options, one of which was to go to my primary care physician, who I had already talked to and knew didn't have tests. One was to try to get tested at the hospital that the patient had been admitted to, but I got denied from them because I was not an admitted patient and I did not have admitting privileges at that hospital. So their employee health refused to test me. And then the other plan was to try to get a test done by one of the private testing agencies. But what most of us don't know, and by those private testing agencies, I mean LabCorp or Quest. Mm-hmm. What I didn't know at the time was that LabCorp and Quest weren't allowing their techs to do the test. And the reason for it is that the test involves putting a very long probe all the way down your nose. And when you do that, oftentimes you cough and sneeze. It's considered an aerosol generating procedure. Oh. And for an aerosol generating procedure, you have to be in appropriate PPE, which for COVID-19 is gloves, a mask, and goggles. So since LabCorp and Quest technicians were not approved to be in those high-risk aerosol generating procedures, they would not be doing the test. What I was able to find out was that I could get a test from them, do the procedure myself, put it in a specimen bag, and then give that specimen bag to them, and then they would be able to run the test. But they themselves could not, in fact, put the nasopharyngeal swab down there and obtain the sample. They would run the sample, but they wouldn't obtain the sample.
So a lay person could do that themselves, even though they're not really trained you know,
So
and want to put that probe down there. I wouldn't want to put the probe down, but you're a physician.
it goes pretty far. There's been various agencies looking at how effective having people do it at home is.
Mm-hmm.
I don't think people realize quite how far back it goes. You do have to adjust your head. You go all the way back until you hit the back of your nasopharynx, and then you kind of let it slide down. So there's a very large portion of it that's in your nose. Your eyes tear up. You kind of get this burning sensation, and then you take it out and do the other nostril. So it is not a comfortable test. And part of the issue with having people do
different
it
probe or the same probe?
Same probe.
Same probe.
Same probe goes down there. Yeah, but you do both nostrils.
So you did test
So
it, and how did your test come back?
So what happened with the testing is you take the sample, you put it in the viral medium, we put it in the specimen bag. It was supposed to be frozen, and at that time, for Quest Diagnostics, they were only processing the tests in California.
Okay.
So then the test had to be picked up from California, defrosted at the right temperatures, and then run. Well, 2 days after I got my test, I got a note from Quest saying that they didn't ship it on ice. The specimen had defrosted en route, and they couldn't run the specimen.
Oh, you didn't have to do it again, did you?
So then I had another test.
Yeah.
You know, at this point, I was no longer running symptoms. We were 9 days past my exposure. My fever had gone down, which I was happy about.
Right.
But yeah, I had to drive in to get it done. And I was supposed to be in quarantine all the time. And here I was again, having to get in my car, having to go to a lab facility, having to redo the test. I really thought that once the Board of Health says, no, you're personal under investigation, we need to get you tested, that there would be a mechanism in place for that to happen. Yeah. And there really wasn't. I did get my second test. That one I tested negative on. But I do wonder, because I wasn't having symptoms, whether I would have tested positive on the first test and negative on the second test. I know my patient tested positive on one test, negative on the second test, and then positive again. So we know there's a lot of variation
and you were
in terms of whether you'll, yeah, and there's a lot of variation into whether somebody will test positive or negative. There's a significant false negative rate. I've heard anywhere from 25 to 40%. It really depends on the operator, whether they get enough of a sample, how the sample is frozen, how the sample is defrosted, whether the patient has symptoms or not. And so, unfortunately, a negative test does not mean you didn't have it.
So what does that do for you psychologically? What would that do for an EMS worker that's told, no, go back to work?
It's really stressful. Spending all that time in isolation was really hard. I knew at some point I was going to see a patient with COVID-19. I knew at some point that I was going to need to self-isolate. I thought I would have more time. Looking back, I would have had a junk bag in my car with toiletries, toothpaste, a thermometer,
right.
All of those things ready to go, so that when I chose to self-quarantine, I would have all of those things. That's something that I would suggest people make a plan already for where they're going to go when they need to self-quarantine. Have that ready to go, because you never know what that exposure would be.
And a mechanism for food and subsistence? Yeah.
Yep. I was living in an office, so I had a microwave and a little mini fridge. But I basically ended up eating or drinking a whole lot of protein shakes. But honestly, I really wasn't hungry at the time. I was very nauseous. I had a fever. I had shortness of breath. And what I found was when I would eat something, it would make my shortness of breath worse, because the food would be sitting in my stomach.
Hmm.
And so oftentimes I would drink one shake a day. I lost 12 pounds over the entire process. I just was not interested in food.
So you go back to
Um,
that we were talking about the attitude among, this is an invisible enemy. So not everybody, even the patients, don't like that you're wearing PPE. Is that right?
Yeah, it's been a bit of a challenge, and we're hearing that from all over the country that nurses, EMS, the frontline workers, even the police and highway patrol are saying we can't identify just by looking who these patients are, and so we want to wear a mask at all times. And at the same time, you have administration saying we don't like how it looks when you wear a mask. We have patients thinking that when the hospital has patients who are wearing masks, has staff who are wearing masks, we're constantly cleaning, it makes the ER, the ambulance look dirty. It makes it look infected. And so they don't want to come there. And it's a real dichotomy right now between administrators who are saying, you can only wear the masks with patients that are confirmed having COVID-19, and people who are on the front line saying, I want to wear masks at all times. It also presents a bit of a...
I can imagine a mother bringing her child in with a laceration to the arm and having to come into a bay with people with glasses and goggles. The child's scared. The mother's saying, my child doesn't have it. So normal patients are now feeling abnormal. Am I right?
Yeah, you're exactly right. And it becomes difficult because we want to please our patients. We want to make them feel happy. We want to make them feel comfortable. No one likes going to the ER. But at the same time, we have to protect our healthcare workers, our EMTs, our frontline folks. And we know, even from some of the trauma centers, that they'll see a patient that comes in from a car accident, and sure enough, they'll do imaging and they'll see things on the scan in their lungs that looks like COVID-19. These patients never came in with those symptoms. And so as hard as it is for our patients to understand that we want to protect ourselves, they need to allow us to wear the appropriate PPE at all times. The other thing is that some of our healthcare workers are immunocompromised. They may live with somebody immunocompromised. They shouldn't have to tell their boss or their administrators about their health problems just to get the right PPE. If I haven't revealed to anyone I have cancer, I shouldn't have to tell my manager I have cancer, I'd like to wear a mask at all times. That's private health information. I should be able to say, no, I'm going to wear an N95 mask at all times, and that's just accepted.
Yeah, and that's an interesting thing. I didn't think about that as a former director of operations. You know, I really don't have the right to say to somebody, tell me about your wife, your mother, blah, blah, blah. If somebody comes and says, look, there's reasons that I need to wear PPE, I basically have to give them PPE. Am I right? Or I put myself in a liable situation, I think.
I would think so too. What we're finding out is that people are being told, no, they can't wear PPE. We just had some new rulings coming out from OSHA and the Department of Labor saying that indeed people can bring PPE from home. Before, nurses, physicians, EMTs were not allowed to wear any home PPE that they might have had. We're just now starting to see stuff where we're getting some ability to protect ourselves. But right now, there's really not any penalties for not allowing frontline workers to wear PPE. And that comes from some of the laws and rules that I don't think a lot of people are aware of. So for instance, we have people going, where's OSHA in all of this?
Yeah, I didn't think about that. They're not, certainly not at the press conferences, are they?
So they're not. So let me give you a little bit of background. OSHA started working on something for respiratory illnesses way back, I believe, around 2010. Right now, OSHA only has rules for blood-borne pathogens, hepatitis and HIV. Those things guarantee that frontline workers get appropriate PPE in dealing with blood-borne pathogens. Now, when H1N1 came along, they realized, oh, we need to do something about respiratory pathogens. Well, we got lucky. H1N1 kind of fizzled out. SARS and MERS fizzled out. And so that stuff got put on the back burner. They came out with some safety regulations that were set to get passed in and around 2017. It had gone through the whole rulemaking process, and it was going to protect frontline workers from respiratory pathogens. Well, about that time is when we had a changeover in an administration, and those rules got shelved. And they have not been picked up since. And so, although there are rules that say that I get gloves when I'm dealing with a bloodborne pathogen, there is not a rule right now that says I get a respirator when dealing with somebody with an airborne pathogen. Well, now, I work with a group of physicians that are working to change that. And what they are asking for is an emergency order from OSHA implementing that 46-page summary that was developed in 2017. That order was initially placed in the first stimulus bill. It is called the COVID-19 Healthcare Workers Protection Act of 2020. It was introduced by 2 House of Representatives and 2 senators, and it was part of the initial stimulus package. Well, the American Hospital Association, AHA, lobbied hard against it, and at the last minute, it was pulled out of that initial stimulus bill. Because of that, we don't have the ability to fine hospitals, fine ambulance companies, nursing homes for not giving us the right PPE. The head of OSHA has come out and said, we're offering guidance and that should be enough. For those of us who've been denied N95s, who are being told that they have to re-wear stuff for days, if not weeks at a time, that's not good enough.
Well,
we have a good set of rules.
Whoever your physicians are talking with, have them email me, because I have some inside connections and have been able to help with some FDA clearances and things. And I want to get the frontline workers protected, so we'll do that. What kind of?
I definitely will.
What kind of closing remarks do you have? I mean, the bag with clothes, underwear, toiletries, that's a great suggestion for everybody. And that should probably be, secured someplace in a safety garbage bag or whatever, so it's not compromised as well. But, we have 150 ambulances coming into New York, which is, to me right now, Dodge City. And
yes,
everybody seems to be looking at Dodge City, and they're not looking at New Orleans, they're not looking at Philadelphia, Detroit, as much as they are Los Angeles and New York. But those 150 ambulances are coming in with dedicated EMTs and medics who may not have the right PPE. They're working under a totally different system. So there's going to be a lot of fear and confusion. Any advice you can give to them? I tell them every patient to me is a suspect right now.
Yeah, every patient is a suspect. I think that everyone should be in their N95 and their goggles at all times. We're very good about wearing gloves. We forget the goggles. That's when I have to remind people on. But we've dealt with significant pathogens before. We've dealt with Ebola. We've sent healthcare workers into a variety of compromising situations, but we always protected them. And it's so important for people to realize they have to protect themselves. Wear the N95, do the battles with administration. Now, in terms of personally what I would advise them, have a jump bag ready to go with your things. What you need to survive for a week or two, where you may not be able to come home when you have a fever. So clothes, a thermometer. I have a personal, I was just looking at, I have a personal pulse ox that I had with me so that I could monitor my symptoms. So I wish I would have had everything in a jump bag prepared. For those of us who are parents, start figuring out who's going to be watching the kids and how you're going to explain this to the kids. It's scary for them. Start figuring out how you're going to do meetings over the phone. So for instance, for dinner one time, we had the phone propped up and I was able to join the kids for dinner. I think another thing to think about is for people to decide when they're going to get out of their gear for work. So there are two options. You can have your vehicle be dirty or not, meaning you can decide after a shift to get out of all of your clothes, wipe down your hands, wipe down your phone, and then travel in the car home. Or you can go home in your uniform and then get out of all of your clothes and your gear, your shoes at home. If you decide to get out of your clothes and shoes at home, that means your car is a dirty space and you should no longer be transporting your kids or having people in it. If you decide to get out of all of your gear, take your shower, clean up, decontaminate yourself at work, then you keep your car a clean space. So for me, I knew my car was a dirty space. I was changing out of my uniform at home in the backyard. And so I haven't had my kids in my car, but that's another thing to think about. And then lastly, what was that?
But no, go ahead.
And lastly, think about where you're going to self-quarantine at. Airbnb, hotels are starting to allow healthcare workers to stay there. Because I know of some people who have tents in their backyard. I know of some physicians who have rented an RV so that they don't have to come home. And so thinking about where you're going to go when and if you have to self-quarantine is important. And I hate the idea that our EMS workers are working 12, 18 hours and then sleeping in the back of a Honda Civic in a Walmart parking lot. That is just a failure of medicine right now.
And we also know that as you're tired, you basically get drunk and you make mistakes. You make medical errors the more tired that you get. And that's when you're going to let your guard down. I also see on YouTube people that are fashioning ways to put a bag over their patient, exhaust out, that they can give them mini neb treatments. And I don't want to get into a lot of policies here, but if I was the director of operations again, you're not going to give mini nebs. You're not going to do anything that causes the patient to cough or sneeze. Intubation would probably be with an eye gel versus a tube. And that's hard for some EMS workers and probably yourself, that, you know, we normally would intubate somebody, but you can't, or we normally would give them a breathing treatment, but taking them 10 minutes and maybe they struggle a little bit without that mini neb is still going to protect you, your family, your grandmother.
Then that's true. And that's because we want to help so much. Mm-hmm. And we have to remember, you can't help anybody if you're sick. And so protecting you and yourself is important. And you're important. You're important enough to take the 5 and 10 minutes it takes to put on PPE. You are an important enough person in healthcare to make sure that you feel safe when you walk out that door. No one is going to protect you and your family like you are. And you should never set yourself on fire to keep somebody else warm. You should never risk your health for someone else. We have had emergencies before. We have had communicable diseases before. And we know that if we do not protect healthcare workers, that we won't be able to help anyone.
Yeah, and you know, we have to go, but I really want to thank you. There's so much that we could say. We had Kathy West on the other day, and she talked about the fact that the exhaust fan in the top of your roof that you don't always turn on, keep that bad boy turned on, circulate your air. Don't circulate your air from the outside inside, and make sure you're getting the air out by turning your air conditioning on. There's so many little things and questions, and that's what this show is going to be all about. So, Brianna Ireland, I thank you so much for being with us, and we'll be back and check up on you.
Thank you so much for having me on, AJ, and thank you so much for everything you do. I know that this is a really trying time for a lot of EMS workers, and to have GEMS be ahead of the curve and telling people what they need to know really helps with the fear and uncertainty. So I want to thank you, and I want to thank all of your staff that are working so hard for all of us frontliners during this epidemic.
Okay, thank you very much, AJ
Thank you.
Heitman, and we're out for